Good afternoon, and my name is Mary McCune, Policy Director at CDA, here to facilitate both presentation and live discussion of this year's House resolution focused on diversity, equity, inclusion, and belonging. This policy resolution is being brought forward to the delegation from CDA's DEIB work group that has been working hard on this issue since the onset of the year. This work is incredibly important because it helps to bring together not only CDA membership, but the profession and the future of the profession as a collective whole to ensure that dentists, dental teams, and the communities they serve are represented and heard with dignity and respect. The DEIB work group has gone through many iterations of this policy document to ensure that the background material on this subject matter is appropriately and relevantly presented, because no element of this discussion can be discussed in a vacuum. Past policies, both at the government and association levels, have impacted many historically underrepresented communities with echoing repercussions that, at its most simplistic form, can be represented in statistics. However, the impacts of these policies run much deeper and more interactive conversations like the one that we'll have today to ensure that CDA can move forward on this issue with one voice and requisite support. Today, we'll have three members of the CDA DEIB work group with us to go deeper in detail for the need for this resolution and what brought us to this place today. Dr. Ariane Turley, current CDA president, is here with us, also serving as co-chair of the work group. Dr. Wallace Bellamy is here as both a work group and CDA board member who was instrumental in helping put together a cohesive background on the issue at hand. And lastly, Dr. Rick Nagy also joins us today as an active contributor of the DEIB work group and past CDA president. We thank them for their commitment to this work group and resolution. And at the conclusion of this presentation, we'll have a live Q&A session for participants to interact with the presentation materials and speakers. In addition to this resolution, the CDA DEIB work group also helped to produce several other work products, including a Women in Dentistry event at this year's CDA Presents in San Francisco. We'll also be having a three-part webinar series beginning later this month. Dr. Turley will share more information at the end of this presentation. Please plan to join us and invite others to join with you. We hope this series will not only be informative and meaningful to you, your patients, your staff, and your practice, but also help keep this very important conversation moving forward. Thank you. Now over to Dr. Bellamy, who will share a little bit more about the historical context behind this policy resolution.
Thank you very much for attending this presentation of CDA DEIB resolution. Why is DEIB important? In 2021, the CDC declared that racism is a serious threat to public health by understanding the country's past policies affecting Black, Indigenous, and people of color, BIPOC communities. The result has had a deleterious effect on BIPOC communities' oral and overall health. Dentistry as a profession has a responsibility to prioritize combating systemic racism on behalf of the dental team members, patients, and the community at large. In 2015, the Department of Health and Human Services found numerous examples of health inequities, including lower life expectancy, high blood pressure, and lower rates of influenza vaccination. This can be extrapolated to the COVID vaccinations as well, and a strain on mental health. Racism is based on an ideology of inferiority under which the dominant social group discriminates, disempowers, and marginalizes a minority group. It can affect access to oral health and clinical decision-making by influencing the social determinants of health. Federal, state, and local policies such as redlining, housing programs, or discriminatory wage practices segregated many BIPOC communities into neighborhoods separate from white groups. Redlining is a discriminatory practice in which services are withheld from potential customers who reside in neighborhoods classified as hazardous to investments. These neighborhoods have significant numbers of racial and ethnic minorities and low income. Chronic diseases and segregation. Segregation brought and continues to serve as barriers to meaningful access to healthcare. Healthcare deserts, which are areas without access to hospitals, primary care physicians, and dentists, exist in these areas and lead to poor health outcomes. It correlates directly with low levels of education and limited employment opportunities. And as a result, segregation has resulted in separated communities living in impoverished and disadvantaged neighborhoods with low quality housing, high pollution, and reduced access to healthy foods and other necessary services for healthy lifestyles. These and other social factors have led to higher prevalence of chronic diseases and mortality rates within these populations. Food and nutrition still remain challenges to many American families. Communities of color in particular are more likely to have lower levels of nutrition. Three major contributing factors are poverty, access to safe, clean, fluoridated drinking water, and proximity to grocery stores. These food deserts determine the type of nutrition readily accessible and affordable. As healthier, less processed foods are priced at a premium, many families will opt for caloric-dense foods with a higher content of preservatives such as salt, which can cause elevated blood pressure levels and obesity. And additionally, marketing of oral health damaging foods and other products such as sugar-sweetened beverages and fortified alcohol and tobacco specifically target communities of color. And as a result, Black and Hispanic communities have twice the rate of untreated dental caries than white communities. Hunger affects oral health in a variety of ways. The lack of calcium and other nutrients lead to weaker teeth. Less chewing causes less saliva production to wash away bacteria, and unhealthy food causes tooth decay. Lack of education and proper home oral hygiene, especially in children and pregnant mothers, leads to undesired oral outcomes. Elevated sodium intake can lead to high blood pressure, which has been linked to higher incidence of periodontal disease and, if left untreated, early loss. Economic factors pertain to more than just the ability to access adequate food. It compounds poor oral health because people are unable to access dental and healthcare services due to the lack of clinics, transportation, or the ability to attain a job with a livable, sustainable wage, and thus acquire and maintain adequate dental benefits. Actual care and treatment can differ between Black and African American patients and white patients. A 2016 study found many white medical and dental Black people have a higher pain tolerance than white people. Of all the participants, 73% held at least one false belief about the biologic differences between the races. An example of these beliefs include Black people having thicker skin, less sensitive nerve endings, or stronger immune systems. The researchers note that these beliefs are centuries old, and some 19th century doctors used them to justify the inhumane treatment of enslaved people. An example of differing care is randomized clinical trial on recommendations for root canals for some patients. It was found from participating dentists that root canals were more likely to be recommended for white patients than Black patients, and that Black patients were more likely to be recommended extractions irresponsive to the patient's condition. Another study exploring the impact of race regarding surgery recommendations following oral cancer diagnosis. And it was found that Black patients were less likely to receive surgery referrals than white patients, irrespective of their cancer diagnosis. And with that, I will pass the presentation over to my colleague, Dr. Nathan. Rick.
Thank you, Wallace, and hello, everybody. In addition to lower health outcomes, systemic social inequalities also affect the demographics of healthcare providers. California is one of the most racially and ethnically diverse states in the country and is projected to become even more so in the future. However, the California dentist workforce is not reflective of this diversity. The racial ethnic composition of Californians dentists are overwhelmingly white and Asian, comprising 88% of the dentist workforce, but are only roughly half of the statewide population. Additionally, California dentists are overwhelmingly male, representing about 2/3 of the dentist workforce. Only 15.2% of the 2016 dental school applicants nationwide were underrepresented minorities. In order to shift the demographics of the dental workforce to more accurately reflect that of patients, schools must build on existing recruiting tools and pipeline programming. The value of having a more diverse dentist workforce and dental school experience is hard to quantify. However, it is certain that the educational experiences of dental school is enhanced by a student body that has a diverse background and experiences. Additionally, a more diverse dentist workforce will help to address both oral health disparities amongst communities in BIPOC dental shortage areas and the issue of general distrust for healthcare professionals. There are several areas in which the dental profession can increase diversity. In dental offices, this includes hiring more minority staff, providing interpretation translation services, providing materials with images of minorities, ensure waiting room materials are diverse, mandating diversity training, and recognizing holidays for various cultures. In some communities, partnerships have narrowed the gap of care as well as created mentorship opportunities for aspiring Black dentists. School sealant programs have proven to be a cost-effective care for children who might not have received care, while creating interest in the dental profession as a future career. In dental schools, careful revision of the admission process can begin to create further diversity. Leadership in academia, the oral healthcare system, and organized dentistry must also be reviewed. Often, senior levels in healthcare do not reflect a diverse population, further hindering profession-wide changes. Many minorities believe that the challenge in career progression is due to their status as an ethnic minority. All-white interview panels, inappropriate interview questions, and recruitment practices that highlight unconscious biases are just a few ways diversity is hindered in dentistry. Unconscious biases are social stereotypes about certain groups of people that individuals form outside their own conscious awareness. Everyone holds unconscious beliefs about various social and identity groups, and these biases stem from one's tendency to organize social worlds by categorizing. For example, when a person thinks better of someone, it is because they believe they're alike, and when they think less of someone, it is because the person is different to them. Minorities cite examples such as being passed over for promotions in favor of their white colleagues and would only be considered upon exhaustion of white applicants. Ethnic minorities and internationally qualified dentists also face bias, including hiring biases due to their immigration status. 27% of all California adults report their oral health as poor, while only 21% of all California adults reported their overall health as poor. 21% of white adult Californians reported their oral health as poor, while 30% of Black Californians and 30% of Latinx Californians report their oral health as poor. Dentists of color cannot always join the current tripartite structure. The National Dental Association was established in 1913 for dentists of color because of membership denial in the ADA. The Hispanic Dental Association was established in Texas in 1990. The Society of American Indian Dentists was also established in 1990. The Civil Rights Act of 1964 opened up avenues of membership for Black African American dentists of color. However, it was not until the late 1960s and early 1970s that some associations would allow dentists of color to join their local societies. In 2010, the ADA issued an apology for not taking a stand against discriminatory membership practices in the 60s and 70s. So with that, Dr. Turley, please take over.
Thank you, Rick. What can CDA do? CDA has provided consistent leadership and commitment to combating systemic access barriers through several initiatives, including developing and implementing the Access to Care report, advocating for the expansion of telehealth, and supporting Prop 56, which has funded Medi-Cal dental program fee increases, the State Office of Oral Health, and county-level dental public health infrastructure. CDA now moves forward to address the systemic social inequities that contribute to access to care barriers and disparities in oral health status. We'll now go over our 4 priority pillars. Commitment. Establish CDA as a transformative leader in anti-racism and social justice education and research within the profession. Education. Cultivate an inclusive and equitable anti-racist environment by enhancing racial DEIB knowledge for all members and staff. Advance careers among historically unrepresented groups in oral health and within the organization. Advocacy. Stimulate and promote evidence-based discoveries and their translation to reduce racial health disparities, promote equity, and improve oral and total health. There is need for ongoing DEIB work in dentistry. To narrow the gap in oral health care, the oral health profession must take measures to help end systemic racism, including creating and promoting safe places for anyone to discuss and engage in diversity and inclusion concerns with confidentiality and receptive understanding. What has brought this resolution to light? Because of the disproportionate impact of COVID-19 on communities of color, this resolution seeks to establish new and further define policy on addressing systemic barriers to equity in dentistry and overall health. The resolution builds upon earlier CDA policy directing the association to focus on social competencies of oral health care providers. Research documenting ways in which social impediments disproportionately affect communities of color and the lack of diversity in the dental workforce have been cited. Bylaws and policy implications. GAC, our Government Affairs Council, will be able to evaluate legislation through a wider lens that includes broader societal impacts to patients, acknowledging that institutionalized social inequities affect oral and overall health. Proposed resolution and benefits for CDA members. It positions CDA as a healthcare leader and a partner in addressing a public health crisis. Raising awareness within dentistry of systemic barriers that lead to health inequality and proactively seeking to address this public health crisis will provide CDA members with the tools to better serve their increasingly diverse patient population and incorporate more inclusive solutions to access to care. And I'll pass the next slide to Dr. Bellamy.
Thank you, Dr. Turley and Dr. Nagy. So the DEIB policy statement resolution is as follows. Health disparities exist across California that disproportionately affect historically underserved communities due to systemic, social, and economic inequities. As such, CDA reaffirms its commitment to combating barriers which permeate the healthcare system and other parts of society that lead to poor health outcomes for patients. CDA shall do this by implementing additional measures that address societal impediments beyond the dentist-patient relationship.
Thank you, Dr. Bellamy. I would like to share with you our current DEIB workgroup efforts, CDA DEIB resolution and accompanying white paper that is before you, CDA Presents Women in Dentistry event, diversity surveying of our CDA leadership, diversity surveying of the California dental academics, and in October and November, we're going to do CDA DEIB three-part programming. I would like to take the opportunity to recognize and thank our workgroup members for their time and contributions on this very important policy for CDA. I would also like to thank Mary McCune for all of her work, research, and support on the development of this policy. CDA has upcoming DEIB programming, and we're hoping that you will join us for the following meetings. Part 1 will be October 27th, Part 2, November 3rd, Part 3 will be November 10th, and please look for your emails and with more information on how you're able to participate.